Thank you, everyone, for joining. We're very excited to be here today with a wonderful panel talking about future proofing the OR and navigating technological integration. And my name's Alex Saw. I'm a hip and knee surgeon in Fremont, California, past president of the Anterior Hip Foundation, but obviously honored to be joined by the panelists you know here. They don't need any introduction. They have really pioneered, developed, and continue to grow anterior hip replacement and its associated technologies. And that's what we're here for tonight. So we're very proud to have Dr. Joel Matta, Dr. Jonathan Yerasimides, and Charlie DeCook here this evening. We'll let them introduce themselves and then begin the discussion on technology and anterior hip replacement. We'll start with Dr. Matta.
Yeah, thank you, Alex. Yeah, Joel Matta, uh, specialized in hip surgery. I was a primary instigator of Anterior Hip Foundation and I guess to a degree Anterior Approach in North America also. So when we're talking about technology, just to talk about what does technology mean, to me, it means a fairly broad thing. And I think people talking about technology now, they're talking about like tech companies and working with computers, working with uh, online uh, modalities, working with the internet. But to me, technology is a lot of things in the OR. And so if we look at where hip replacement has been in the past, and I remember Charlie DeCook, one of our panelists, giving a great talk where he was showing Charlie replacing a hip, where you got the patient laying on a standard operating table, you make an incision, you're got these hand instruments, you're pounding with stuff, and um, things. And Charlie was just pointing out a little things have changed in so many years. So technology, I think, has been part of anterior approach. I've certainly advocated, and I would just say the orthopedic table, which began as I was using the Judet table, and then the HANA table is a piece of technology that was the first one I thought that I was involved with it enhancing anterior approach. So the function of the table, just to think of it as kind of, in a way, a robot. It's a mechanical device manipulating the skeleton to get access to the skeleton and also to just help with surgical exposure during surgery, help with capability to get x-ray, and also take an assistant out. And I think we're going to get to that OR efficiency later on, but just to take an assistant out. So it's kind of a, a use, I think, of a robot that's very useful for hip surgery, something to do gross functions of holding and manipulating the bone. Now, Jonathan and I were just in Scottsdale, and I gave a talk on history of anterior approach. And what was interesting was that if what I looked at what Robert Judet did in 1971 to what I started doing when I started anterior approaches, it was really the same. He had an orthopedic table, and Judet had come up with basically the modern hip prosthesis, porous coated collared stem with a porous coated acetabular shell, modular polyethylene modular balls. So what's changed probably particularly is having real-time method to determine accuracy. And that's kind of where we focused with anterior approach. So it began with just bringing in the fluoroscope, just checking so you'd see the x-ray. The principle was just usually waited till after surgery to know when the x-ray was, what the x-ray looked like, but now we could get the answer right away. And out of that did grow some technology. And what happened was that we started teaching courses, and we had the HANA table, we had satisfactory implants, and surgeons would, and we'd tell them, okay, now you just bring in the C-arm and you can see where the cup is. You know where your cup is, and you can bring in the C-arm, you know what your leg length and offset is. But it turned out surgeons really struggled with that. They had a hard time just eyeballing the x-ray and knowing what it was, and probably even people really experienced with x-rays have the trouble too. So this introduced the technology. First, we were just overlaying X-ray films and looking at little films we'd print out from the image intensifier, but it brought in some efforts for technology, and like OrthoGrid became one of the early companies for their utilizing technology to measure these things. Is the cup correct? Is the leg length and offset correct? And there's been evolution in these technologies, of course, but basically what it is that the C-arm produces a digital data. I first started doing anterior approach, it wasn't digital, and so you didn't have the digital data, but now you can plug in a tablet computer to the C-arm, you can get out the digital data, and then you can reformat on the screen of the tablet computer. You can get quantitative real-time information if things are going correctly. I'll just make a couple other comments on technologies with hip surgery. And one is that the way posterior approach was done for years, because it was really very hard to get an x-ray or get an assessment of what you're doing during surgery. It was all based on preoperative planning. And so it's based on getting an x-ray ahead of time, making measurements from the x-ray, figuring out where your neck cut should be. So you measure the neck cut, the stem goes in, and you figured out your ball length, and also templating for the cup. So preoperative planning isn't out, but I mean, I think there's some misdirection now with technology. For instance, with the, what some entities are doing, getting a CT ahead of time, and from the CT you plan the whole procedure, and it's probably increasing accuracy. I think it's good for posterior approach, but you know, some companies are working toward robotics to do the procedure according to the plan, but then they still never check with an x-ray till after surgery in the recovery room. So I think if we have a focus on using technology, and like I'd say, the way anterior approach has really changed from today to today, is that we're getting better assessments in real time of what we're doing. So we're improving our accuracy. And I think we're finding out accuracy is very important to the patient, not just for hip stability, but also hip biomechanics, so they get the maximum function. But it's more important to know what we have in the OR. That's the bottom line. I think this is kind of my own feeling on it, but I don't think you need a robot, or you don't need something guiding you to get the stem in the bone, or to get the cup in the acetabulum, or even to ream the acetabulum. You can see it visually. You can see on the image intensifier where the reamer is. So I think this is kind of a holdover from posterior approach, that it was all about preoperative planning. So now you make preoperative planning even more extensive. You get a CT, and then you're programming a robot, or programming whatever technology to get the correct results. Or I don't think we really need that preoperative plan and programming, because the surgeon can pretty easily put in the stem at different depths, can position the cup where they want. The information we really need from technology today is from knowing what we have the final check, so we know what we have, because the surgeon doesn't have difficulty really obtaining what they want to have. You know, you have a lot of options to change leg length and offset. You can position the cup, but the thing that some of the companies, like I mentioned, OrthoGrid, Radlink was an early one. Then we had Joint Point, but these are more focused on knowing what you have during surgery. So in a sense, I'm kind of a little bit against preoperative planning, or I'm against extensive preoperative planning, because especially when we're talking about expense and efficiency, throw in a CT scan, throw in computer planning, and then it's not something you need to do. The best system, the best technology is where you probably do a rudimentary pre-op planning. You look at the x-ray, make sure there isn't some important deformity or implants that are going to get in the way. You get a templating that gets you in the ballpark. It's not going to be exact. It's not your final decision, but this is very brief, easy to do on your couple days before surgery. You just flip through some x-rays. But the bottom line, then you go to the OR and the technology can give you answers, what you have, where you are in real time without extensive preoperative planning, which I think I like the idea of looking away from extensive preoperative planning.
Well, that's great, Dr. Matt, and you've definitely given us a lot to think about there because you have the unique perspective of being in the innovator of anterior hip replacement in North America, seeing it through its development. And as you were talking, I was sort of thinking, and correct me if I'm wrong, it seems like with the anterior approach, a lot of the evolution early on was the technique, right? Figuring out how to do the surgical procedure, make it reproducible, and improve upon that. And then maybe the next phase was the instruments, having the right instruments, having the right equipment, how to perform that surgery well. And then the implants got modified and even better. But those things seem to have gone to a point where there's still improvements, but maybe not as dramatic, as much room as you said in the technology realm. And it's if you look at it, it's interesting in your multiple decades of teaching residents and fellows and surgeons how to do this, it's probably very different each decade, right? First it was leg lengths, then it was overlays, and as technologies became more available, you adopted them and continue to teach them. It's very interesting to see how your philosophy has changed and where your focus has changed. I personally have always enjoyed listening to your talks about how to interpret an x-ray and the proper way to do it and planning, but that can be challenging, as you said, for many surgeons. I think the beauty of these current technologies, like you said, the orthogrids or others, is it simplifies it. It takes out the guessing game, it takes out the errors, so surgeons of all experience types can very quickly get the information they need. I think that's really what's amazing with today. It's really technology for the masses, if you will.
Yeah, I think just to comment on that, I mean, with the technologies, I think the ideal technology, though, it can just work for you, and I know OrthoGrids works with artificial intelligence, which is, I think, can be an important future. So the AI can help read the X-ray, help position, give answers. But as the technology gets more sophisticated, so the surgeon can rely on it, you still need another pathway where you need to be able to look at it and say, the computer's telling me something, but it just doesn't look right. I got to be able to manipulate the images or take another kind of manual path in there. So, and I think some of the technologies have that, some of them don't. I think OrthoGrid is working on both pathways, but I think we need both pathways.
That's it's great to hear perspective, and again to hear how your philosophy has changed, so that others can adapt and adopt as new things become available. And that brings up a question I have for Jonathan Yerasimides. For those of you who don't know, he's truly a master hip surgeon. He can really pretty much do any surgery through an anterior approach, and he probably only needs a fork and a spoon to do the surgery. So he doesn't need any advanced technologies. But Jonathan, can you tell us why when you can really do any surgery however you want without it, why would you adopt a new technology? What's the need you found? Or maybe it wasn't a need, maybe it was just something you found made something better. How did that work
Uh,
for you?
yeah, and it's actually funny you mentioned that, Alex. First off, um, yeah, I'm Jonathan Yerasimides. I'm from Louisville, Kentucky. I'm a hip surgeon. Joel's my mentor, and so when I came out of fellowship, I said I just want to be a hip surgeon. That's all I want to do. My partners told me that was just ridiculous and it wasn't going to happen. You couldn't make a practice out of hip replacement only, and it's since come true. But replacing a hip with a fork and a spoon. Uh, I have, unfortunately or fortunately, replaced a hip without any retractors whatsoever, using a curved Mayo and a tonsil as my retractors. I had a broach handle, but my retractors I did not have because we had none left or clean. And I was able to do an entire hip replacement with a curved Mayo and a tonsil as my retractors. So it is possible, but I don't recommend it. Nonetheless, uh, I guess I was an early adopter of technology, as Dr. Matta said, with the HANA table. But then I went into a period of stagnation where I was doing overlays, and I was the caveman of the group because I've been friends with Charlie and Joel for 15 plus years, and Joel almost 20. Um, but I just got so used to doing what I was doing and that it was working. I didn't see a benefit in moving on to some kind of technology that I wasn't sure was going to add to my practice, because I was like, I like doing overlays. It gives me control. I can adjust my C-arm pictures to exactly how I want them, and I know that it's going to be correct. I don't know that technology is going to do that same thing for me. Um, and then I've now been a full adopter of OrthoGrid's overlay technology for the past year, and found that it is actually extremely accurate. It actually saves me time in the operating room. I don't have to wait for printouts. I don't have to put cover gloves on. I don't have to go to the whiteboard and look at them manually. And it shaved time off my case and been extremely accurate. Um, the AI technology thing is a real deal. I wasn't a believer in it. I was like, oh, it's hocus pocus, it's marketing. But it is a real deal. And there's a variety of technologies, from the automated broaching stuff, which I'm starting to adopt now. I'm not a full adopter yet, but I'm using it and I'm testing it out in small quantities, because that's how I look at new technology, just like with OrthoGrid. With OrthoGrid, I did at least 10 days of surgery, which is somewhere, between 80 and 100 cases, where I would use OrthoGrid and I would print out manual overlays and I would compare them because I didn't trust it. I'm like, I don't know what this thing's telling me. Is it true? Is it not true? And it took me a while to adopt it, to trust it, because I had my way that I liked and the way that worked for me. And that's what I'm doing with other technologies now, like the automated broaching. I'm using it, but I'm using it sparingly, and I'm trying to see if it works. And if it works for me, and if it does end up working for me, then I'll fully adopt it. But I'm taking it in little pieces. But I guess maybe I'm a slow mover. I don't know, Alex.
I think that's a great approach, Jonathan, because most hip and knee surgeons traditionally have been, if it ain't broke, don't fix it, right? If it's working well for us, we're not going to suddenly change everything at the risk of making it worse. But I think your adoption of technology is very fair, and it's how I do it as well. If you know something's working, you don't have to give up on it in its entirety and abandon and go to something brand new. Overlap and compare them to what you know, so you can test that technology how it works in your hands. Because for some, they might not use the technology quite correctly, or they might be misled. The technology is only as good as how you use it. So I think that's a great adoption. So if someone like you is using it, that says a lot for everyone else, because you're probably one of the few people who don't need it. But as you said, it saves time. It's accurate. It's one of those things where you really just have to try. I think once you try this AI technology,
Yeah.
it's very hard to go back. And forgot to mention, Jonathan is our current president of the Anterior Hip Foundation. And for those of you who are looking for one of the best meetings really in the country each year, it's this May in Nashville. Jonathan has put together an amazing agenda and faculty and program. So just a plug there for the Anterior Foundation and Jonathan's hard work this year. Well, that brings me to my next question. And for those of you who don't know Charlie DeCook, he's out of Atlanta, Georgia. He's a teacher, an innovator, an educator, prior president of Anterior Hip Foundation. Really, probably everyone on this call has learned a ton from Charlie, as myself, I have. He's really a leader in efficiency and surgical technique. And if he's looking into something, I'm always eager to see what it is, because you can always learn something from Charlie. And so, with that, I wanted to see, Charlie, what your thoughts are. We're talking about technology. You've been at the forefront of that. We're talking about it with anterior hip approach, but why do you think the adoption in hip replacement has been different or slower than knee replacement? Is it just the nature of the surgery that one, knee surgery maybe is more amenable to these type of robotic technologies? Is it that there's a greater need? Maybe surgeons need the help more with technology in knee surgery, or Is it just because the ease of the solution is simpler with knee surgery? What are your thoughts of the different rates of growth in the hip and knee market with technology nowadays?
That's a great question, Alex. When we think about that diffusion of innovation curve, that actually it came out in the 60s with uh, uh, an Iowa professor is looking at the adoption of hybrid corn among farmers. And he was trying to figure out why some farmers seem to adopt this hybrid corn faster than others. And, a lot of it has to do with communication. Obviously, I think difference between hip and knee surgeons is very little. I think a lot of it has to do with access. The hip is a harder place to access, and traditionally they've been on their side. So what Dr. Matta taught us is that that's foolish. We should be laying supine on a HANA table, and I think that just opened the door. When you think about what's happened in the last 20 years, as Dr. Matta has done anterior approach, it started with the technique, but then quickly added to it these innovations, these technologies, and I can think of a few. So we had joint point at the beginning. We had Concise, what was called ME1000. These are all technologies that weren't able to flourish in other areas, and it did with anterior approach. And I think it has a lot to do with the surgeons that really adopted the anterior approach. These are surgeons that, frankly, wanted to buck the system. They wanted to try a new way. And I think that permeates through not only anterior approach, but actually our foundation. We're all part of the board of the Anterior Hip Foundation now, and it really kind of exemplifies what we believe in, and that is, listen, as Satya Nadella said, our industry does not respect tradition; it only respects innovation, and I think we believe the same thing. I mean, I think there will be a day, Dr. Matta says this all the time, where something will do better than the anterior approach, and we need to be ready for that. I think we're ready for anything that makes us better. For me, the most important thing is any technology has got to make me smarter, it's got to make me faster, and it's got to make me better. Those three things, and that came from a recent book, Smarter, Faster, Better. But that really exemplifies, we have big ASCs in the state of Georgia. We have to really be critical of any innovation that we bring in because of the costs associated with it. So we really have to hold these criteria. And if you can't prove to me a smarter, faster, better, you're going to have to pay for it yourself if you want it in the ASC. So that's kind of our philosophy in terms of that diffusion of innovation. So I think it's not just hip surgeons. I think it's anterior surgeons that saw innovations, said, boy, there's got to be a better way. And that personality, I think, just embrace other technologies. And frankly, we should hold that to ourselves to start to try and embrace other technologies, right? So we've used C-arm for a long time. I think a lot of anterior approach surgeons were drawn to cup position, leg length offset that we could never really appreciate from a posterior approach. There will be a day where we won't use a C-arm anymore. And I think we have to embrace that at some point, as long as it's as accurate as C-arm is. And it goes what Joel talked about earlier, right? We have to embrace things like no more assistance. We have to embrace surgical impaction. We have to embrace different ways of reaming. All these things that we should start thinking about in a unique way. And I think anterior approach surgeons do that, I think, a little bit better than a lot of other surgeons.
I
That's
couldn't
really well
agree
put,
more.
Charlie.
Yeah, and I always feel like a simpleton when Charlie talks, because it's I feel like the knuckle dragger that I told that I was going to be when I was going into orthopedics. But uh, it, it it's all true. It's all true. I think this anterior approach surgeons, I think from the beginning, um, like Charlie said, we're bucking the system and continue to buck the norm and to try to look outside of what is considered normal and standard. And I think it's actually pushed the entire community of hip replacement surgeons to think in a different way now than they did 20 years ago.
Yeah, I think that's one of the main points, Jonathan, that you have to throw out old ways of thinking. And one of the phrase I like to use is don't don't do anterior approach like you did posterior approach, or don't try to do it like you did posterior approach with shuck test and moving the leg around and feeling the ankles or something like this. We have to question a lot of concepts. You know, Charlie, I think with the smarter, faster, better, I think it'd be a natural and it'd be happening quicker in medicine, except that medicine is so regulated and with the government funding that if it were like more like other industries with more free market capitalist forces, you'd move smarter, faster, better all the time. But like you said, you're trying to justify this to some third party that has ulterior motives and doesn't really understand hip surgery and the like. It's actually the market drove adoption of anterior approach. So it drove the adoption. The market's a positive force, I think, in medicine, that it drove adoption of anterior approach. The market was patients wanted it, surgeons found the patient did better, surgeons found they were attracting patients. But that's kind of, I don't think with smarter, faster, this innovation, we don't just face surgeons that don't want to innovate or don't want to adopt technology. There's all these external forces controlling medicine that make it difficult.
You know, one of the big changes, Joel, to that point is this transition from hospitals to ASCs. You know, the hospitals in the last 5 to 10 years have made it very hard for surgeons to really get technologies in the OR. They put you through these VAC committees, which, you know, basically you have to basically beg to get a new technology into a hospital system.
Right.
And that has really stifled a lot of our ability to really innovate, to appreciate these new technologies. And it's been, frankly, very hard for these companies to get into these hospitals. And I think this move towards the ASC, where it's really more surgeon controlled, you know, people talk about, well, is the ASC going to be a good place for innovation? And I'm telling you, I guarantee it's going to be a better place for innovation because surgeons are in control of it. And frankly, we're curious individuals, right? We want to try something new. Even if it's worse, we want to at least try it for ourselves and see. And the ASC has allowed us to do that in ways that the hospital can't. So I'm excited for the innovations that we're going to see in an ASC because we're going to be cost conscious. Listen, it affects my bottom line when I'm using expensive technology, so it better work well. But at the same time, it's going to allow me the freedom to not go through a 6-month committee to get the technology that I want.
Yeah,
Jonathan, I don't know about you. I don't,
yeah,
if it's the
and I
same
think
in Kentucky.
it is, but I think I think a lot of right now at ASC, like the cost basis for these innovations are based on hospital finances and hospital facility fees. As things go more and more to the ASC, these innovations are going to be forced to get, more cost effective because right now they're putting a price point based on a hospital facility fee for a total joint, which is significantly more than an ASC is. So they're putting a higher number on it. As things go more to ASCs, I think the industry numbers for cost are going to decrease because they're going to have to. They can't charge a hospital and an ASC the same price when an ASC's facility fee is significantly lower. So I don't think it's apples to apples right now as far as the ASC versus the hospital.
Yeah, I think one other thing that just it's kind of an aside, but it's with this that I thought for years that if I was going to start a campaign in healthcare outside of anterior approach, I guess it'd be support the right of the patient to pay for healthcare. And so a big problem we have right now is that if you're a Medicare contracting hospital or surgeon, you are not allowed to, the patient's not allowed to pay anything independently. And a lot of insurance contracts are written like that too. So I think the path forward, which I would think would be a better one for a lot of technologies, is that you can offer it to the patient. You know, your insurance doesn't cover it, and then they have an option to pay extra to get it. So I've talked to AOS or Political Action Group a number of times about this. I don't get anywhere, but the patient should be allowed to pay. And then if patients, a large number of patients are paying for something like the to use orthogrid, to upgrade their accuracy, insurance companies are going to start offering it. They're going to say, hey, our policy, you get this technology covered. You don't have to pay out of pocket. Come leave your old insurance. We're going to pay for this with your new policy. I think that we just need more market forces going on.
I think you're right, Joel. I think we've touched on the dynamics of who's going to pay for this advanced technology. We're being reimbursed less, and we're trying to use more advanced technologies, which are costly. Who's going to pay for that? The hospital, the ASC, the surgeon, the patient. Who's going to cover that cost? And I think you're right. I think eventually, at least in my opinion, the patients probably will have an option to have a upgraded surgery, use a different implant, pay out of pocket, because that's almost happening now with these CTs you referred to before. When insurance aren't covering these preoperative CTs, many patients just pay for it out of pocket because no one's covering it. So clearly the patients want it. Clearly the patients can afford it and see its value. And hopefully you're right, other payers will see that so that we can continue to innovate. Because otherwise, with declining reimbursements, as Charlie said, these companies and surgeons can't afford to use things that are more expensive, take more time, and are less efficient. That doesn't work.
Well, I think Alex, you just hit the nail on the head. Less efficient. If you can have a technology that is more efficient, like I mean, I feel like orthogrid with the simplest of things, not making me wait for a printout and going and doing manual overlays. If I can shave 5 minutes off a surgery, um, per case, and I'm doing 10 in a day, that's 50 minutes. That's almost 2 additional cases I can do in a day in the same amount of time. So I can justify using the technology because it allows me to do more surgeries in a day. So if technology can make you more efficient and make you have the ability to do more cases, it's going to be adopted. If technology makes you less efficient and adds time to your case, there's zero reason to use it, especially when it
No,
costs you money to use.
you're absolutely right. That's a simple equation, and then you're right. That's a great point, Jonathan. And it's a perfect segue. Thank you for setting that up. We have to hear Charlie's discussion on how to scale OR efficiency. He's obviously a master at this, but without sacrificing quality. So, Charlie, obviously, your institution, your program, you do it incredibly well. How do you give recommendations to another surgeon or another group on how to institute this in their own program? How do they really assess what they're doing and make the hard decisions of what's really efficient and what's really providing quality?
Yeah, I think you have to start from the beginning. So we're lucky enough to have surgeons come every day. We're in their OR, and the reason why is just because our efficiency is just off the charts, and people just don't believe they can. We can do 12 to 14 cases by noon. But the thing you have to start with is the data. And I don't know why we haven't used time in our operating rooms for the last 30 years, but we really haven't. Time's been out there, it's on a wall, but nobody really pays attention to it. And if you think of a company like any company, Tesla, Delta, any company is keenly aware of time, and they use time as a weapon. So they compete against other companies like Amazon with time, right? Why do we all use Amazon? We use Amazon because Jeff Bezos realized that, first of all, the customer's number one, but it's always going to make sense that the customer is going to want something that's cheap and you deliver it to them as quickly as possible, right? So Bezos has used time as a weapon, and we have to use that in our operating rooms as well. We have to start setting expectations of not only how long our particular task takes in the operating room, but how long everybody else's. If we don't set expectations for, listen, a turnover should be 15 minutes, or when a patient gets in the room to when I want to cut is 10 minutes. If we don't start setting expectations, we'll never change anything. And the basis of that is data. So we developed a program called One Team that we're really proud about. That's very easy to bring into any operating room. and it basically makes time transparent. And when time's transparent, then suddenly everyone is on the same team, meaning everyone is trying to work towards the same goal, which is to get better, right? So I want to be better as a surgeon. And how do I get better as a surgeon? Well, I look at my individual steps in a total hip and say, where am I struggling, right? And for me, it has been and will be getting the head out, right? So Dr. Matta does a fantastic job of that. I still suck at doing that. What are the ways in which I can get the head out more efficiently? Now, I'm great at some other parts. The exposure I'm very efficient at. I have minimal dissection. I'm very good at exposing the femur very quickly. But if I'm not paying attention to how long it takes for each individual step in that procedure, then I have no way to improve. So in our operating rooms, our fellows, throughout the course of the year, we track their time and we see how long it takes them to do a case. And we see where they're struggling, if it's on the femoral side, the acetabular side. The interesting thing, what we've learned with time with anterior approach specifically, is that people think it's about femoral exposure, and it's not. People waste so much time on the acetabulum, I can't even tell you. They waste so much time on leg length, offset, bringing in C-arm, using any technology. That's where the real wasted time is, and has very little to do with exposing the femur. So that's a long-winded version of saying, listen, if you want to affect change in your operating room, if you want to become more efficient, you have to bring time into your operating room.
That's a
Charlie.
great point. Yeah.
Yeah.
Go ahead, John.
No, the first question I have is that, and it's going to be on the viewers, everybody that watches this, they're going to be like, well, God bless, great Charlie, but I'm working in a hospital. My first team, clocks out at 2:15. They couldn't give a rat's ass how many cases they do by 2:15. How the hell am I going to convince them that, they're going to get paid the same, whether they do 3 cases or whether they do 6 cases in that room? How the hell am I going to convince this team that they need to work harder to get paid the same in a hospital setting?
Yeah, that's a great point. We were able to do it pretty effectively in the hospital, but we had the right teams, right? So you have to have the right personalities that want to do it. People think you have to pay them or incentivize them. Believe it or not, us surgeons and nurses and scrub techs, we're incentivized by money, but we're also incentivized to do good work. And if you're part of a team, they're proud of being with you. They are excited. Hey, we're doing it better than everyone else. So if you create the right team, even in a hospital, you can do this. But to your point, listen, it's an uphill battle in a hospital for sure. You need 60,000 meetings with, all these different
Right.
levels of administrators. It can become a real pain. Much easier to accomplish in an ASC.
Right.
But for those stuck in a hospital, the only advice I can tell you is get out as quickly as you can.
Yeah, exactly.
You shouldn't be in a hospital anymore. I don't care if it's
Correct.
primaries or
Yes.
residents. You should run from the hospital. That's even more incentive to leave the hospital. And if you are currently in a job where you can't get to an ASC, you need to change your job.
Nope.
Yeah.
The point, exactly.
Yeah.
For anybody who's watching, this week, today is Wednesday that we're taping this. On Monday, I did 10 total hips and left my ASC at 5 after 1 o'clock. On Tuesday, I did 4 total hips and left the hospital at 12:05, both with 2 rooms. So, and they were all primaries. So this wasn't a hospital revision surgery. 4 primaries at hospital, 12:05, 10 primaries, ASC 1:05, same start time. It is ludicrous if you're in a hospital and have the ability to be in ASC. And Charlie, I'm guessing your technology is not going to be adopted at a VA hospital anytime soon.
You never know. Even a VA, maybe we can fix even a VA. We actually had some surgeons at a recent course that were stuck in a VA.
Yeah.
And you're right. We may never be able to fix a VA.
Well, that is the
Which is
epitome.
terrible. I mean, we should fix the VA.
right.
We love our veterans.
Yep.
But you're right. It probably
Well,
never fix it.
That's efficiency, Jonathan, right there, and the difference between ASC and main hospitals. You are 100% right. And Charlie, you hit on some great points. Bob Booth has always said there's no such thing as a good slow surgeon. And I think it's something that as surgeons, we've never wanted to look at time. I think we've never wanted to judge ourselves. It's just a metric we've never held ourselves accountable for. But you are 100% right. Unless you look at it, you won't know. And so, a lot to learn from Charlie and his program in terms of other metrics to evaluate yourself to really gain efficiency, but importantly, still have excellent quality. I mean, right? You're still doing the surgeries the way you want to. Patients have tremendous outcomes. You're not sacrificing anything, but there is more than enough room to make improvements with all of our surgeries.
It also helps you to be honest about your technology, right? I mean, I hear a lot of robot surgeons talk about how they're time neutral and all this kind of thing. Hard to believe that with these first generation robots that you can be time neutral. I'd love to see it, and I'd love to prove it with time. But any technology, right? So automated impaction is a great example of that, right? It absolutely takes me less time if I'm using automated impaction, for sure. It absolutely has less time if I'm using a navigation device for my length and offset. Absolutely. And we know that because we're measuring time all the time.
That's a great tip for all the listeners. And we've talked about how to adopt these technologies in the OR, and what we haven't talked about, and maybe we alluded to a little bit, but what about learning curve? Any of you have thoughts on how you tell a surgeon who's adopting new technology how to assess what the learning curve is and what's an acceptable learning curve? Right? Some technologies will work in some surgeons' hands, and some surgeons just will never be able to adopt it. Any of you have thoughts on or advice on a learning curve?
Yeah, I think that's the next step in technology, and I'm speaking specifically about OrthoGrid because since I've used it, I've seen the AI capabilities of it with just identifying landmarks like teardrop, lesser trochanter, and being able to automatically propagate those landmarks up with an X-ray. I think the next step in this journey is for a program when somebody brings in C-arm and shoots an AP pelvis that the program tells them tilt the table left, tilt the table right, because so many surgeons can't recognize or don't take the time to recognize when their pelvis is level, or if they're doing overlay, uh, prints or electronic overlays for their leg links, they don't recognize that the rotation of the X-rays is off. And if we had technology, and we can teach this to computers, I mean, OrthoGrid's proved it with AI, we can teach these machines to help surgeons identify when an X-ray isn't exactly correct or when their images they're trying to overlay aren't exactly correct. And it can help them to correct that discrepancy and lead to better results.
Yeah, I absolutely agree. I love my implant rep, but Jonathan, I'm sure you'd agree, it's great to not have to depend on them to try to find the teardrop or these landmarks on X-ray. To have an AI that will find it consistently and immediately, it's so fast, has really been eye-opening. So I agree with you. I think this technology is going to advance so quickly that it's
Yep.
going to give us information we currently don't have to hopefully help us do these procedures better. And that's a great segue. Joel or Charlie, what do you think the future will be for this technology? What do you think is the next area where technology has an avenue to really impact us as anterior hip surgeons, or where's an area where you think there's a need? If you had to guess where we'll be in 5, 10 years from now, what would you think if you had to bet would be the technology that's next adopted?
Why don't you go, Charlie?
Okay.
Give you the
Um,
future.
a few things, a few technologies that I think are going to go a long way. Number one is, we need to encapsulate what Dr. Matta can see that I can't see. And by that, I mean, Dr. Matta has an appreciation of the pelvis in 3D space that I don't have, right? So I see it in 2D and AP X-ray, and I have a hard time seeing anything other than that. But if we really start talking about leg length, offset, hip centers, I think in order to really appreciate that, we need to see that in 3D space. I think there are technologies that are coming that will allow us to see this 3D without expensive CT scans or other imaging modalities, that will allow us to see us in 3D, where that I'm going to appreciate the hip not as good as Dr. Matta, but better than I do now in a two-dimensional view. I think that's the first thing. The second thing I will say is that when we develop those type of technologies, it will allow us to help with inventory. I think what's happening now as we see the prices in the operating room going up, implant prices and everything, we have to start taking ownership of how expensive it is for an implant company to have 300 different implants for you for one case, right? In my ASC right now, to give you an idea, I have literally millions of dollars worth of inventory sitting there waiting for me because I can't express to my implant manufacturer that, hey, in 4 weeks from now, I'm going to be doing a size 4 stem with a 52 cup, right? That has to go away, right? We have to, as surgeons and owners of ASCs, start taking the initiative to start really managing that inventory. Not only the implants themselves, but also the instruments, the expensive cost for these instruments and the turnover of those instruments has to change. And the only way to do that is really to have a good enough technology that we can not only know what the sizes are appropriately, but communicate that well in advance of the surgery. Those are two exciting things I'm excited about.
That's great. I think that's a lot, and we're always all going to follow you very closely to see what answers you come up with, because I'm sure if anyone can, you can. Any other panelists? Any other final comments? This has been an amazing discussion, and we look forward to talking more about it in May at our Anterior Hip Foundation. The four panelists here today, we are also the hosts of the first Anterior Hip Foundation Traveling Fellowship, which is starting next month. We are very excited. So this will be a year after year fellowship where we'll have new applicants and new traveling fellows to bring them to various sites and show them surgeries and have these great discussions. And we look forward to continuing them in May in Nashville under Jonathan's leadership. But can't thank the panelists enough for their contributions and discussions this evening. We could speak on this for hours, but any final comments, any final words of advice you'd have for our listeners, for those looking to adopt new technology? Dr. Matta, we'll start with you. Any final words that you have?
I would just say I've been a speaker and a listener here, and so as I listen to everybody else, it gets the wheels turning in my own brain, and happy to be part of this discussion. So I think that's what our discussion was tonight: stimulation for thought.
That's great. Thank you so much, Jonathan. Any final words?
It's always fun to hang out with friends and talk hip surgery. And for any of you guys watching out there, come to Anterior Hip Foundation meeting, because that's exactly what you're going to get. You look at us, you think, oh shit, we're up on the podium and we're blah blah. We're just a bunch of dudes, and at the AHF meeting, you're going to hang out with us, talk to us, just have some drinks and have fun. It's a very relaxed meeting, and we're a big family. We were a small family a decade ago, and we've grown to be a bigger family, and we're always looking for new family members. So, come be a son-in-law or a daughter-in-law. We'd love to have you.
Well said, Jonathan. And Charlie, you get the final word. Any advice to our viewers?
Yeah, I think every surgeon should come this year because one of the most exciting sessions is going to be the Shark Tank, and that's the opportunity for us to see surgeon innovators present to the sharks. And this year's sharks are fantastic. They're leaders from DePuy and Stryker and Zimmer Biomet. And what you're going to see is surgeons presenting new ideas, new technologies to a bunch of sharks that really have seen a lot of innovations. And they're going to give not only those presenters a lot of great feedback, but they're going to give ideas on how we should start thinking about developing our own products and how we would bring those to industries. So I think that Shark Tank session is going to be awesome this year.
It always is, always a highlight of the meeting. Charlie does a great job with that. It's truly a place to be on the forefront of new technologies coming in the operating room. So have to come and see that. You're right. And want to thank the panelists. I think really the theme is you have to have an open mind, no matter where you are in practice, whether you're a new surgeon, an experienced surgeon, at the end of your career, you can always learn something if your mind's open, if you're willing to listen and learn. The moderators, the panelists on this webinar, you can learn so much. I always love learning from you all. Every conversation. Look forward to continuing that at the meeting. And I thank you for joining us tonight, and thank you everyone for joining us on this webinar. Until next time, we'll see you in May in Nashville.
Awesome,
Okay.
guys. We'll see
Thank
you.
you, Alex.
Thanks, everybody.
Thank you.